So I want to thank everyone for coming. This is my first talk here. I've spoken in the past, kind of little presentations here and there, but this is the first one where I had to wear a tie in the place that I work, where I usually wear athletic shorts and ankle socks, so it's a nice change. But you know, when it comes to things like this, I'm very humbled by knowledge, so hopefully you guys have a similar experience. Today is just meant to not confuse you about something new, but about enlightening you about something new and making you open to considering something about your health that maybe you weren't considered of in the past. Does anybody here feel like they have a vestibular condition? Well, we'll answer that at the end. Yeah? Okay, yeah. Examples of conditions that you would treat with vestibular therapy, sure. The room is spinning and... Okay, very good. Okay. Hopefully at the end of this you can diagnose and treat him, and he doesn't have to come in here at all. Yeah, I'm just kidding. But again, let me introduce myself more formally. I'm Klaus Dobra. I'm a physical therapist here, and I just started doing vestibular rehab. I got my training at the American Institute of Balance in Largo, Florida. Spent about a week there under Dr. Richard Gans, who's a fascinating character. He's a character by every sense of the word, but he's extremely brilliant, and he writes a lot of the protocols for vestibular treatment and vestibular assessment. So it was really wonderful to work under him. Or learn under him rather. But we'll get started here. So before we get into what it's actually all about and what it is and dissecting it a little bit, I think it's really important to consider why these things are important, why they're important to know, and why they're important to consider, because ultimately we're talking about your health. So I'm just going to run through the next 3 slides, I think, just some, rocket fast, just go through some bullet points. So 2 billion people will be over 60 years of age by 2050, and that's 25% of the US population. Okay, so people are getting older, and they're getting older by significant numbers. So by the year 2030, the population of individuals 65 and older will double. By 2050, those over 85 will quadruple, and Medicare costs will reach almost $1 trillion. So there's a financial incentive to being well for all of us, because we pay into that system. Dizziness is the #1 complaint of people over 70 years of age. 85% of vertigo and balance dysfunction may be inner ear related. 50% of individuals over 70 years will experience BPPV, and we'll go into that in a little more detail. You guys will know what that means in a little bit. And older adults with BPPV have a greater incidence of depression, falls, and reduced activities of daily living. They have a limited capacity to do the things that they want to do every day. Falls are the leading cause of traumatic brain injury and bone fractures. Falls are the leading cause of accidental death in persons over 65. 20% of those who sustain a hip fracture from a fall will die within 1 year. And those who fall, 20% will require placement within a long-term care facility, which I'm sure you're aware of. And in 2000, falls amongst the elderly accounted for 1.6 million ER visits. So we're talking about balance. We're talking about the ability to have a sense of awareness about where you are in space and how you move through it. So it's important to consider why that's important. It's because of the repercussions of not having a system that's acute or well tuned to understand that. So we're going to get into talking about the vestibular system. Now the vestibular system, it's comprised of, it's right next, so this is the hearing apparatus, right? This is your tympanic membrane where sound hits, goes through these bones and into the cochlea, that's where we perceive sound. That's the part that physical vibrations translate to a chemical cascade that goes to the brain, and they say, okay, this is what I'm hearing. And right attached to that, very intimately connected to that, is your vestibular system. And that's what you see as those canals. So just to go into a little bit of anatomy, because it'd be senseless to talk about why this is important or how it functions within you if we don't understand what it looks like and how it physically looks and operates. So attention to these canals. Evolution is a really, really wonderful thing. And what it does, what evolution has given us, is this ability to sense where we are in the different directions we're going. I mean, if you're familiar with how, like, the electronics of a telephone work, of a smartphone. It has a gyroscope inside. These things that tell it where it is and how you're holding it in your hand. Our brains have a much more finer tuned version of that. And these semicircular canals, they're called, have fluid in them. And when we move, that fluid moves. And when that fluid moves within it, that's how we perceive velocity, that's how we perceive motion. Now, if that fluid isn't moving how it's supposed to, or if perhaps the nerves that innervate that system aren't working like they're supposed to, then we experience a deficit in our perception of of our balance and how we are in space. So, and then over here, where these semicircular canals come down, we have this structure called the ampulla, and within that, that's more of this is the actual organ that moves when that fluid moves, and that tells us whether we're turning left, or whether we're turning right, or whether we're looking up, or whether we're looking down. Come on in, have a seat. Welcome, thank you for coming. And then attached to that system of organs is another one called your macula, and that gives us our sense of gravity. And you can see here these little rocks. We actually have rocks in our head. And the way that those kind of bombard in that organ, I know, right? That gives us information about gravity and where we are. If we're on our side, if we're upright, if we're on our backs, if we're leaning forward, right? Those are the things that give us the information about our place in space. I don't want to go into too much detail over this because I could dissect the anatomy all day, but I really want you guys to pay attention to these semicircular canals, which there are 3. One goes superior, up, one goes horizontal, and the other one goes back. And so they all actually are situated in these fine axis points in these very specific orientation to make sure that they give us the complete picture of where we are. But just generally speaking, just have some awareness that the vestibular organ is comprised of these 3 canals, and that's what gives us our sense of position in space. So equilibrium, it's a fancy way to say balance, right? It's your ability to calibrate and make sure that you're on a boat and the boat is swaying. You're going to sway against that boat to try and stay upright so you don't topple over. It's our ability to stay upright and when there's a perturbation or some influence in our environment that throws us off. So I'm going to actually skip to these first. If you consider, there's 3 different systems that feed into your sense of balance. The first 2, which are external, right? They're in our outside world, are your visual and your somatosensory. Your visual. So if you were to stand up and you see how you're swaying and how you're moving, you stand pretty still. As soon as you close your eyes, most people start to sway a little bit. It's because our vision plays a very, very important role in our ability to understand the world around us, because it gives us that contrast. It gives us that perspective of where we are relative to other things, and that helps us calibrate. Somatosensory is our sense of touch, our proprioception, it's the sensation we get, the information we get from our feet about where we are, how the ground is moving, is the ground level, and that feeds into that system. But again, it's external. It's a force from the outside giving us that information. What's unique about our vestibular system, which it contributes 2/3 of the information needed for balance, is that that's our internal organ. It's inside, and it gets information from the outside world by our movement through it. So whereas these are relying on the outside, this is totally contained. And so if that system is damaged, it doesn't get the input that it needs to be able to function correctly. So sometimes you may need to see a therapist to have that system recalibrated, okay? But a really important thing here is 2/3 of the information we need for our balance comes from this internal system. And then, so we take this information from those 3 systems, and then we react. What is that reaction, right? So you're on an unstable surface, and it starts to teeter to the right. You react by moving and catching yourself, right? So our central nervous system has this really wonderful ability to take this information and then give us a physical manifestation to protect ourselves, to protect our heads, to protect our bodies, to make sure that we don't fall. So it compares all these things, it calibrates it within that system, and then it produces an output, and that output is catching yourself when you trip, right? And this is just a visual. It's a bit crude because it came out of the book that I got at the American Institute of Balance. But these are those three systems. They feed into what's called your vestibular nuclei. You have two centers, so you have two vestibular systems, one in your left, one in your right, and they correlate to a central processing area where that information, it's just like a data hub where that information goes into, and then that output is into these three additional systems, which I'll talk about. Your vestibulo-ocular reflex, pertaining to your eyes, your vestibulo-spinal reflex, pertaining to your body, and your vestibulo-colic reflex, which is your neck. Now, the vestibulo-ocular reflex maintains stable vision during head movement. If I turn my head, my eyes stay steady. Or if I look at a target, I'm able to keep my eyes on that target. This is a way for that we use our vision, right, to calibrate how we're supposed to be oriented in space to make sure we don't fall. We know that the car is moving, we know that we're not moving. That's what this system is telling us. The purpose of the vestibulospinal reflex is to so your body has to react to some kind of perturbation, right? You get pushed and your body reacts to keep you upright. So that vestibular system, when your head is oriented in a specific way, your body has to be positioned. So he's tripping, but then he's falling and he's moving his body to try and stay upright to protect, ultimately, if you really want to get down to it, to protect his head. And then the vestibulocolic reflex acts on the neck muscles to stabilize the head. Because if your neck and your neck and your body aren't working together, then you're not going to be able to stay upright because your neck is what holds your head up. And I use the example of a chicken because there's actually, when we were taking this course, they showed us this video of a chicken, and no matter where you move the chicken's body, its head stays right into place. And it's that. So it's your ability for you to stay oriented and keep your head upright and positioned in a way that's going to protect you while you're tripping or while something happens to you. So the primary function of the inner ear is equilibrium, i.e. gravity and velocity detection. How we're moving, what direction we're moving, how fast we're moving, so that we may react to keep ourselves, our brains, and our bodies safe. And every professor I've ever had has used a cartoon, so I just threw it in here because I thought, I don't know, maybe they know something I don't. But I love Calvin and Hobbes. So, we're going to get a little sciencey just for a moment, but I really want you to understand how this system works. So for all intents and purposes, we're going to talk about, what does it mean when there's a discrepancy between those two sides, right? So let's take it to somewhere normal. It's called physiological nystagmus, not related to physiologic. You have two systems, and they're right here, right? Let's take our left side and our right side. I'm looking straight on. When I turn my head to the left, this side is getting input and is becoming hyperactive. This side is going down. This discrepancy is what your central nervous system reads. Okay, he's turning his head to the left, right? And everything can react accordingly. When those two systems are equal, for example, when you're just looking straight ahead, although they're both getting input, they're getting information, it cancels each other out. So you don't experience the world as spinning, right? Everything is where it is. But then, if you're talking about something more pathological, right? Let's take a system where on the right side, or let's go on the right side, you have a less functional system. So here, just at baseline, you have this. Now, number one, when you turn your head to the right, and it comes back to 0, right? So this is 0, and this goes higher, it still feels like you're going to the left. When you're going to the left, it really feels like you're going to the left. But even at rest, this system is higher, this system is lower. That's why you get the sensation of movement when there is no movement. Because those systems are uncalibrated, right? So again, I'm going to review that just one more time because I think this visual is really important. This is where we are. This is where we should be. This is where dysfunction lies, right? This system is not working correctly. So there's an incapability of those two sides to communicate, to tell you accurate information about the world around you and where you are in it, and that's what you can experience when you're talking about your vestibular ocular reflex, about your eyes. That's where you experience vertigo. The room is spinning when it's not spinning. Does that make sense a little bit? So when you're talking about what we just discussed, it's a true pathology. It's called a vestibulopathy, right? There's damage to the blood supply to that system or the nerves to that system. When you're talking about somebody who, concussions, there's some trauma to that system, but it's damaged in some way, right? Irreversibly, the system is damaged. But there's this whole other aspect of vestibular therapy, this whole other patient population, that suffers from what's called benign paroxysmal positional vertigo. This is where the rocks in your head get a little problematic. Essentially, what this is not a pathology. It's not pathological. It's more of a mechanical issue. There's things in one place that should be in this other place. So these rocks in your head that are supposed to live right here get dislodged and go into these semicircular canals. Now, we talked about before, right? What's in those canals? It's fluid. When I turn my head in one direction, that fluid moves in the other direction. That's what my brain perceives. It's the information it's getting about what my movement is. Okay? But if these rocks get dislodged, right? They're called autoconia, just for reference. When they get dislodged and they start to live in these canals that they're not supposed to be. And so with a little bit of head movement, those rocks move. But what they do is that they bring that fluid with it. So that's why people complain of bringing their heads back, for example, is the most common symptom. They feel like the world just starts spinning because those rocks are taking that fluid and dragging it with it and giving you the sense of movement and making that fluid move even when you're at rest, and that's where you experience this really intense vertigo. The beautiful thing about this, the beautiful thing about this condition is that it can be treated in one treatment session. So whereas you have this other pathology, right, this real disruption to a system when you're talking about true vestibulopathy, about damage to your vestibular system, that takes time to heal. And we'll talk about what it takes to get to that point. But then when you're talking about this takes no time at all. And this is one of the more common things that people actually come and see an ENT or a physical therapist to treat, is BPPV. And these people, once you treat them, I mean, they're your friends for life, because you just took something that they essentially lived for 2 to 3 years with, and you heal them. You take those symptoms away in one maneuver, and then really seal the deal with another maneuver, and then send them home and they're walking upright. It's really extraordinary. You have to remind them that they can't follow you home typically. So just to review, BPPV is treated with this canalith repositioning, which I'll give you guys a visual example of what that is. It's just a maneuver you perform. And then the true vestibulopathy, okay? Something that takes time to heal because you have damage to a system that cannot be undone. And you have to create compensatory means. You have to create means to be okay with having those issues by using what you have intact and fortifying that and making it stronger. This is exactly what we talked about, but just understand how common BPPV is. But it's tough to tell if it's a true vestibulopathy or BPPV until you go see a specialist. But generally, BPPV is more positional based, right? I lie my head back at night. I have to keep my head propped because if it lies back any further, the room starts to spin. So on assessment, when you take BPPV, you take the patient, you lie them down, you turn their head a certain direction, you lie them down, and you ask them how they're feeling. If they tell you that they're getting symptoms of vertigo, that means that it's indicative that they have this more mechanical disorder of BPPV. So symptoms are of short duration, 10 seconds to a minute. You get intense vertigo, nausea. Sometimes they'll have to throw up, get really sweaty just because of that anxiety. And then between attacks, there's this kind of like unsteadiness, right? When you get that attack, you get up and you're like, no, I have to sit down. I don't feel comfortable standing up. And then again, here, and I think why I'm here today is because people suffered from these things for years, and they're just like, it's just a part of being a human being in the world, and they don't get the treatment that they need because number one, they don't know why it's happening. Number two, they don't know that somebody can help them. So I want to show you this video. This is the testing maneuver. So let's say you're a patient that comes in. You say, every time I go to lie my head down at night to go to sleep and turn to my right, the room starts to spin. I have to stay propped up. I can't lay down on my back. It's been happening for 2 years. So you turn the head 45 degrees to the right, lie them back with the pillow under their low back, and here's where I would look at their eyes. If it's positive, you see their eyes go into a state of nystagmus, where they start to beat left and right because to them the room is spinning and their eyes are trying to catch up with that. And that's what you would see. And we don't need to go into the different kinds of nystagmus. And then, to treat it, it's actually one of the great things about the Dix-Hallpike, which is the maneuver that's the name of that maneuver, is from right there, you see that a person is positive, you can go right into the treatment and take that feeling away. And that looks something like this. So the head moves, the fluid moves, right, in those canals that we discussed. Here's the rock in that canal. This is a person at rest, but because that thing has to travel just because of gravity to get down here, it moves the fluid with it, and that's what you're experiencing as vertigo, because that organ is doing its job. It's telling you, it has the information, okay, you're moving even though you're not, and that's what you're experiencing as dizziness. So you take them into that Dix-Hallpike maneuver, you lie them on their back, you look at their eyes, you see that their eyes are beating. Here they want to kill you. You're the worst person in the world. I'll just take you through it because we don't need to wait for this. Turn the head to the other side. Again, at another 45-degree angle. I'll just pause it. And then what you do then is you roll them onto their side and you bring their head down to the mat. Ask them how they're feeling. They should feel a little bit dizzy during the different movements. At the very end, when things settled, you have them sit up and you ask them, how do you feel? You do the assessment again to see if it's worked, and more times than not, they'll have the sensation again, but it'll be much less because you've cleared that debris. What you can appreciate about this is when I say mechanical, I mean here are 3 canals, there's stuff in them, and you're just rolling the head around to try and get these rocks that exist in them just right back to where they need to be. So you're getting from this part of the circle to this part of the circle. It's so straightforward. I think that simplicity is really beautiful because our bodies are just these mechanical things, right? They're physical parts. It's not just this, imaginatory thing inside of all of us. It actually exists, and it can be treated by rolling over to one side and then rolling over to the other. Vestibular rehab is a systematic progression of exercise protocols which reduce or eliminate hallucination of motion, which is dizziness or vertigo, and exaggeration of motion or after motion. So getting up from sitting down or lying down, oh my God, the room is still spinning. And you get that kind of unsteadiness leading up to actually things like leveling out and feeling a little bit more normal. But even though that window can be brief for a lot of people, that can be really dangerous. So how long does it actually take you to get out of bed and go to the bathroom? Not that long. But if it takes you 5 minutes for the system to settle, that's going to the bathroom is within that 5 minutes. That's a circumstance that could lead to falling or hurting yourself in some way that you could otherwise avoid, right? So we don't need, even though that most people live with this because it goes away after a little while, but that little 5-minute window, a lot of bad things can happen, and that's why we try to, hone in and address this because those are when spills and different kinds of falls happen. And what we aim to improve is coordination of head and eye movements and balance and equilibrium function. Okay, so I really want you guys to appreciate the role of your eyes, feeding it, and your neck and your body and all of these things and how they play into you being able to be upright. You guys ever get that sensation when you're driving in a car that the bus next to you starts to move, but it looks like you're moving, right? The system is being tricked. But when the system is defunct, these are the kind of this is the kind of information that it gives you. It gives you false information. That information is critical to be a human being that exists in the world. To be able to stand in front of a subway platform and not be worried that, oh my gosh, I'm going to fall forward. Why do I do this? And why are you here? And why is it important to know about it? And why should you consider it? It's the best or only management. So tough luck. You got me and you have to deal with it. It's cost effective. What was your name again? I was just telling Jennifer, I mean, this is something that you could spend $100,000 of equipment to really, really do the fine tuning and calibrate and find out exactly what's going on. Or you can have a $20 mat on the ground and be just as effective. So it's extremely cost effective. It doesn't require all this intensive kind of overhead to be able to apply. It's non-invasive, it's rehab. It's you moving in a certain way that's going to make you feel better. A relatively short course of therapy, so for BPPV, 2 visits, 3 visits maximum, and for a true vestibulopathy, probably you're looking at 6 to 8 weeks. It's extremely user-friendly. These exercises can be replicated easily at home when you're talking, as a PT. What I try to drill home to my patients is the importance of a home exercise program and staying true to that program and sticking to it. But the beautiful thing about these is that you can replicate them at home. So it's not like you come in here for the 2 days, two times a week that you come and see me, and that's it. That has to be practiced over and over. And the beautiful thing about it is you can go home and do the same exact thing safely. And it restores your everyday function, which is where we want to be. So we're going to talk not about BPPV, not about the mechanical disorder, right, that we were discussing that I showed you those maneuvers for. We're going to talk about who is a true vestibular therapy candidate, right, the 6 to 8 weeks of true rehab. And that is somebody who is stabilized but uncompensated. Stabilized meaning you're past the point of the acute phase where the world was spinning and it will not die down, right? So you have an exacerbation, a flare-up of some kind, you have a concussion and it damages the system, you have a virus and it damages the nerve, and so that system is thrown out of whack and there's an initial reaction to that like, oh my gosh, something's happened. And then those symptoms calm down and they stay static. They stay the same. And then uncompensated is just another way to say somebody who could benefit from it, right? Somebody that isn't able to just feel better from just going out for a walk or doing yoga or something like that. There's room for improvement and they're not getting it from their day-to-day lives. So stabilized, doesn't change, and uncompensated, room for improvement. So again, talking about a true vestibulopathy. So symptoms of an uncompensated vestibulopathy include blurred vision with head movement, specific to speed and direction. I'm walking, every time that I look to the left across the street, I get really dizzy. Every time I look to the right, I'm fine. A sense of after, feeling of exaggerated movement with head movement. So I turn my head slowly to the right, but it feels like I'm whipping my head. And spatial disorientation and balance with head body motion or ADLs. So just that sense, that same feeling of the bus going by. You don't know where you are or where you're moving and where other things are moving and how you're moving relative to each other. Okay? So now we're going to talk about the different kind of rehab that we do here. And there's 3 main principles. Okay, the first one is adaptation. Adaptation pertains more to eye movements. I don't know if any of you have seen somebody get vestibular care, but you know, doing one of these where you keep your thumb in front of you and you turn your head left and right and try to keep your eyes glued to the target, that's really hard for some people. This is this idea of adaptation, of trying to get to your eyes to adapt to moving and being able to stay on a target. And in the same way, it's also a moving target with your eyes staying locked on it this way. And then if you really want to get crazy, it's turning your head but keeping your eyes locked on the target. So these are different exercises to try and calibrate that visual portion of your vestibular system. But that adaptation can, I get dizzy when I turn to the left. Do this for 2 minutes within a range that's comfortable for them. And after 2 minutes, wow, I can turn to the left and it's less uncomfortable. And that's what, so there's actually a gentleman that used to work here, Dr. Purcell, and he does a lot of this work, and he's far more advanced than I am in that regard. But you know, he made me realize what a little nugget of information he gave me was, it's not standardized to everyone, right? You work within the range that those people are comfortable in. I'm not giving everybody the same protocol on the day one. I'm giving them the same concept. But the speed at which they're moving will be different. The range at which they move their heads will be different, because you have to work within what's comfortable into that system while still challenging it. If somebody gets dizzy to the point of falling over here, I'm going to make them stop here, where they start to feel uneasy, but they still feel comfortable enough to do it. And then through this idea of adaptation and through practice, they'll be able to get here, but only if they can get here first, and then here, and then here, and then finally here. And something to keep in mind, like a lot of these treatments, you know, they're going to exacerbate your symptoms, at least initially, for the sake of removing them entirely. But I think a lot of that apprehension comes from people coming and being like, I don't want to feel like that ever. Do not make me feel worse. And that's the tough part to explain to someone. You might feel worse before you get better. And this is an important concept, affected by voluntary motor control and attention, right? It's your being actually focused on that finger or on that target as it's moving that's helping your brain calibrate. It's not a passive entity. Your eyes are locked to one specific point and you're moving left and right.